Good morning, everyone. My paper is Obscure Intracranial Pathology, Manifesting as Acute Acquired Comitant Esotropia, My Experience at an RIO in Telangana, and my co-guide is Dr. Y. Raman. There are no financial disclosures and the ethics clearance was taken. Acute acquired comitant esotropia, a type of strabismus characterized by sudden onset of esotropia with diplopia, often occurring in children, teenagers, and young adolescents, and after complete development of binocular function usually, hence results in successful recovery of stereopsis after treatment. And on motor evaluation, ductions and versions are full and free, so it should not be confused with sixth nerve palsy because due to its sudden onset. So it's classified basically into the Swan, Burian Franchetti, Bielshowski, those caused by intracranial pathology and the rest being idiopathic. My aim and objective is to report the series of cases in our center presenting with the intracranial pathologies and highlight the importance of neural imaging, especially contrast-enhanced MRI. So this was a hospital-based prospective observational study for a period of 1 year at our OPD, with the inclusion criteria being all those patients presenting to Squint with sudden onset esotropia and no previous onset or history of any esodeviation. They were evaluated thoroughly, and all of these patients were sent for a contrast-enhanced MRI of the brain and orbit to rule out any neurological cause before further management was decided. We studied 23 patients in the study period duration, with 14 male and 9 female, with the mean age being 16.6. Now, 5 of these were of those of intracranial pathology, rest were of the varying pathology of 2 of Burian Franchetti, 4 of Bielshowski, rest idiopathic. No Swan type was noted. These are the demographic details of all the 23 patients. The first case is of a 22-year-old female with decrease of vision in both eyes and severe headache. She was advised imaging. There was a tuberculoma of the brain diagnosed. ATT was started for her, and then we could see that there was she's currently on ATT and there's resolution of the esotropia. Second case, again, an 18-year-old female who in 2016 was diagnosed with tubercular meningitis on imaging, and then she presented to us. She had a 15-degree esotropia, but her fundus showed both eyes that the disc was pale, and so when we did a surgical correction, that was basically a cosmetic correction for her. The third case is of a child, 5 years in age, with history of fever since 20 days with sudden onset of inward deviation of 15 degrees. And both eyes, papilledema was seen. On imaging, a supracellular craniopharyngioma was diagnosed, which we see in the images. And the child was lost to follow-up once we had referred the child to a neurologist and a neurosurgeon. Case 4 and 5 were of young females who had presented with sudden onset of diplopia and headache of a short duration, with hypertension and diabetes in this case being seen, with no history of trauma and OCP usage. She had diplopia and esotropia, and on the MRI we could see a partially empty sella sign, with MRV showing partially hyperplastic rest transverse and sigmoid sinus. She was started on acetazolamide for 2 weeks and advised weight reduction, and there was resolution of esotropia and her complaints resolved. This fifth case is again of a 17-year-old girl with 1 month of double vision since 2 weeks. And then she also had 15 degrees of esotropia with both eyes of papilledema. The MRI contrast of brain and orbit had shown mild flattening of the anterior pituitary gland, finding suggestive of idiopathic intracranial hypertension, and the MRV showing lateral transverse sinus stenosis. So these were all the patients, 5 that we found of the intracranial pathology in our study, with the demographic details and the imaging that we had seen. So my study had 23 patients, 5 of them had intracranial pathology. The sex distribution in those 5 was 1 male and 4 female, youngest age at presentation being 5 and the oldest being 33. 2 of brain tuberculosis, 2 of idiopathic intracranial hypertension, and 1 of being a craniopharyngioma case. This was the treatment outcomes that we had seen. So usually we've seen that most of these cases, if comparing it to a Thailand study, there have been cases of Swan type as well, which was seen in a particular study of 16.67, where we had none of them. And usually there has been one Arnold-Chiari malformation case of 3.3% of intracranial pathologies, as compared to 21% that was seen in our study. Similarly, a study done in Romania, which showed about 10% cases of their study showing intracranial pathology, but ours was just the double of 21.7%, thus highlighting that we should not miss any of these intracranial pathologies. Though some studies show that you can evaluate patients based on the neurological symptoms and then think if they have some neurological symptoms, you can refer them for neuroimaging. But sometimes you may not see any neurological sign the first time of presentation. Hence, if we do not send the patient for a neuroimaging, we might miss a disastrous finding and might just treat the patient and then lead to a fatal problem. So it is advised that we should send all our patients for neuroimaging so that we can also know the cause, treat the cause in a multidisciplinary approach, and later, if required, manage the squint and not lead to any fatal outcomes. Thank you.
Thank you, Dr. Devika. I think any acute onset EZO, you should consider it concomitant unless proven otherwise, because you should rule out, especially if it's presenting with a diplopia. So the cases that you presented with a craniopharyngioma or a raised ICT would have been a sixth nerve palsy, a mild form of a sixth nerve paresis, rather than a comitant esotropia, because raised ICTs cause a sixth nerve palsy.
That is how we have usually seen, but this was very surprising when 2 cases, and recently also in the month of January, I saw a 3rd case which had presented, and actually, ma'am, there was no incompetence.
Yes, you might not get incompetence in the early cases. Patient might have, diplopia just for distance, maybe many a times. So that way, very early features of sixth nerve paresis. Thank you, Dr.